Hello, everyone, and welcome to the virtual training on testing implementation for HIV, STDs, and hepatitis C. My name is Cody Schaefer, and I'm the Prevention Services Coordinator working with the Bureau of HIV, STD, and Hepatitis Prevention Program. And I'm happy to be with you today to talk about integration and implementation of these three types of testing strategies. So just as a brief overview, today I'm going to be talking about HIV testing, hepatitis C testing, and STD testing. And for each of these component areas, we'll be reviewing the CDC screening recommendations, testing algorithms, window periods, test types, relevant information related to confirmation, linkage, and reporting, a little bit of context related to third-party billing, and also discussing any special considerations related to each test type. At the end of today's presentation, we'll also share some additional resources that can aid in implementation of these types of testing strategies within your settings. So to get us started, we'll dive right in with HIV testing and the CDC screening recommendations for who should be tested for HIV. The CDC recently updated their screening recommendations to indicate that all adults and adolescents between ages 15 and 65 should be screened for HIV at least once in their lifetime. All pregnant women should be screened for HIV, including those who present in labor who are untested or whose HIV status is unknown. And patients who fall under the following categories should be screened for HIV more frequently based on reported behavior, and this is who we would consider to be our prioritized populations. That includes men who have sex with men, persons who have a history of either past or current injection drug use, persons who have recently tested positive for sexually transmitted diseases or infections, people who have vaginal or anal intercourse without using condoms or PrEP, which is a biomedical HIV prevention method, persons who exchange sex for drugs, money, goods, housing, or anything else that they may need, and persons who have partners who are living with untreated HIV, females who have bisexual male partners, or individuals who have partners who have a history of current or past injection drug use. And this is just a priority snapshot of the screening recommendations. There is a link at the bottom of this slide directing you to the full updated screening recommendations from the Centers for Disease Control and Prevention. I will note that all links that are included in these recorded sessions are available in a supplemental resource sheet related to these so that you can actively navigate to those resources as you need to. What you see now is the testing algorithm for HIV. And when we talk about algorithms, this is the laboratory model for diagnosing a particular infection. So oftentimes, what we're talking about in terms of point of care rapid screening, or even even conventional testing, if you choose to implement your program that way, is this first step in the testing algorithm. So as it relates to HIV 1 and 2, this is the antigen and antibody combination immunoassay. So if you're using a rapid HIV screening tool, either third or fourth generation, the rapid test would act as the first stage of the testing algorithm. But a rapid test doesn't move us beyond that stage. So rapid tests are really just a screening tool or an entry point into the total algorithm. And should a rapid test come back reactive, a conventional sample needs to be drawn and sent to a laboratory so that this algorithm can be completed to identify if there is a current active HIV infection. In terms of test types and window periods, this is important to note. There are several different types of tests for HIV, and each have their own unique window periods. And when I talk about a window period, what we mean is the time that it can take from exposure to HIV for enough of the virus to build up in the body and or to create enough antibodies in the body for a specific type of test to be able to detect the infection. So we have antibody tests, which we also refer to as third generation rapid tests or third generation point of care tests. And these tests can take 23 to 90 days to detect HIV after exposure. And they're commonly used as a rapid screening tool. They're also very common in self-testing kits. And these utilize a finger stick or oral fluid sample specimens that are collected along the cheek and gum line of a patient or client. Then we move on to our fourth generation rapid tests, which are antigen and antibody combination tests. These have a slightly shorter window period, so it can take 18 to 90 days to detect HIV after exposure. Also commonly used as rapid screening tools, and they do use a finger stick sample collection, so processing a whole blood sample to run those tests. There's also the antigen and antibody combination test, which is the fourth generation laboratory version of this test. Again, with a shorter window period, taking 18 to 45 days to detect HIV after exposure. And this test really is the start of the laboratory algorithm that I showed you on the previous slide, and this does require a sample collection from venipuncture, so a full blood draw. And then the last type of test we want to discuss today is the nucleic acid test or the NAT test. And this can detect HIV in as little as 10 to 33 days. However, it's incredibly expensive, so it's most often reserved to be utilized when the algorithm encounters an indeterminate HIV-1 test combined with a reactive fourth generation test. And what this is really looking for are those individuals who are very early in their HIV infection. So it confounds the algorithm where we may be picking up antigen and not seeing antibody, and we need to do further testing, and that's this nucleic acid amplification testing that you see here. And then there are several common point of care rapid tests, and we indicated this on the previous slide when discussing test types. And I just chose 3 to show you here because these are the ones that we most commonly use here in the state of Iowa. And these tend to be the most commonly used among cohorts across the country. There are other manufacturers of similar types of tests, but given our knowledge of working with these types of tests specifically, we chose to highlight them as part of this presentation. So the third generation rapid point of care test is the INSTI HIV-1 HIV-2 antibody test that you see here at the left of your screen. This is a third generation test with a 1-minute processing time, and it utilizes a finger stick sample collection. Moving on to the center photo that you see on your slide there, this is the OraQuick oral fluid test for HIV. This is also a third generation test. This has a 20-minute processing time, and it's an oral fluid sample collection. It's also important to note that the OraQuick test is the only test currently approved, the only rapid HIV test currently approved for at-home use by an individual in a non-clinical setting. And then on the right-hand side of the screen, you see the Alere Determine HIV combination test, and this is the fourth generation rapid test that looks for antigen and antibody. And this also has a 20-minute processing time and utilizes finger stick sample collection. I did just want to note costs related to each of these tests. The INSTI test that you see here costs on average about $10 per test. The OraQuick test has a market rate of about $40 per test, and the Determine test comes in also right at about $10, very comparable to INSTI. For INSTI and Determine, there are ancillary and maintenance costs associated with the kits. So just as an example, with both tests, you would need to purchase controls to ensure that test kits are working appropriately by running controls at specified intervals based on the manufacturer's recommendations. This is most often when you receive a new shipment of kits, when you start a new lot number of kits, or if your test kits in storage have gone outside of temperature range to verify that there was no impact to their accuracy. So while the INSTI kit comes with everything that you need to conduct each test, a lancet, alcohol, gauze, and bandages, and I should say here comes with everything but the gloves that the test administrator will need. The Determine test does require a supplemental package that includes these supplies as well as blood collection tubes that are used for the capillary blood draw to go into the actual kit itself. So just market cost of the kit itself is not the only consideration when evaluating whether and which type of point of care or rapid test you may be using in your setting. And the last thing I'll say here is that while these tests are an effective tool for screening for HIV, it is very important if you are going to use these types of tests to understand and communicate to the clients that you're serving that these types of tests are only screening tools and that laboratory confirmation is required to diagnose HIV. You should also work with patients to develop a self-care plan during the time that they await these results, and this should include at minimum, the following components. Who are you going to discuss your test result with if it's positive? Do you have a support network? Also, counsel the clients not to broadly disclose their diagnosis and to await confirmatory testing results. Specifically, if you're using the Determine test, because this is a fourth generation HIV test, it does have an increased sensitivity to contribute to early detection of HIV. But with that increased sensitivity, there's a decreased specificity. So we do have a higher rate of encountering false positives with this test. And that's why I say it's important to counsel clients not to broadly disclose that they've been diagnosed with HIV prior to receiving their confirmatory test result. And also, at every opportunity, you should be counseling clients that living with HIV is not what many perceive it to be. Medications are highly effective in managing HIV and reducing risk that HIV may be transmitted to future partners. Uh, Essentially, the bottom line is that HIV is a chronic and manageable infection, very comparable to diabetes or heart disease or any other chronic managed disease that we see here in the United States today. So if one of these tests, if you're using a rapid point of care test, or even if you're using a full traditional or conventional laboratory test, if the test comes back positive, there is the process of confirmation, linkage, and reporting that you will need to go through. So if an individual is identified as living with HIV, the laboratory algorithm will confirm that, whether you've started with a point of care technology or if you started with a venipuncture obtained and sent to your laboratory. But either way, Iowa law does require that the diagnosing provider and the laboratory that conducts confirmation testing report the results to the Iowa Department of Public Health within 7 days. And I just want to stress here that there is no required reporting to the IDPH if you have a rapid test that is positive, but do not have a confirmatory result. You're only required to report once the infection is confirmed. That being said, if you diagnose or if you identify an infection using a rapid point of care test and you're unable to obtain a confirmatory sample or the client doesn't consent to the confirmatory sample, it would be an ideal time to engage the Iowa Department of Public Health so that we could pursue collection of a confirmatory sample and provide the necessary support and linkage to that individual should that be needed. To report HIV diagnoses of an adult person, you must complete a form called the Iowa Adult HIV/AIDS Case Report Form. These forms can be sent to the IDPH by U.S. mail or can be reported over the phone. For a copy of the form or to report a case via telephone, you can contact the HIV surveillance coordinator, Elijah Jada, at the phone number listed here. I will note that these forms cannot and should not be faxed to the department due to the sensitive nature of the health information obtained within them. I also just want to take a moment to note here that confirmation reporting and linkage can be challenging, especially if it's not something that is coming up very often in terms of your practice. And you may want assistance in delivering an HIV diagnosis to a client or referring and linking them to medical care and other support services. And so I would just like to inform you that Iowa has a very robust network of state and local disease intervention specialists who can assist you in this process. So you're encouraged to contact them prior to meeting with the client when delivering a confirmatory result, because oftentimes they may be able to be present if necessary or be available to you by phone at the time designated when you're going to be talking to that individual. These staff people are the same individuals who will contact persons who are diagnosed with HIV to offer partner services. And this is a process where the DIS will help them ascertain which of their previous or current sexual or needle sharing partners need to be screened for HIV. And the DIS can provide the individuals with tools to notify these partners themselves, or they can notify partners anonymously on behalf of the client. So DIS are really a vital tool in how we confirm, link, and provide support around diagnosing individuals with HIV. And I would highly encourage you to familiarize yourself with who the DIS is in your region and how to get a hold of them. And then I'd also like to say that linkage to care is more than just referral to medical care when it comes to having diagnosed someone living with HIV. So the following actions are all considered to be linkage to care activities when addressing a new HIV diagnosis. And this includes referral to an appropriate medical provider, referral to partner services, which we discussed in the previous slide, confirmation of medical care engagement within 30 days, which is an important benchmark for HIV health outcomes, referral to Ryan White Case Management and other support services, referral to behavioral health, mental health, and other social support services that may be identified as needs for the individual, and then benefits enrollment and navigation support. And I have these color coded really just to illustrate that you don't need to do all of this alone. And this is the importance of building those relationships with your local disease intervention specialists. So items listed in purple will be addressed with assistance from a DIS during the result delivery process, should you choose to engage them in that process. And then items listed in teal at the bottom will be addressed by a Ryan White Part B case manager, to whom the DIS can facilitate the referral and linkage for individuals who have been newly diagnosed. And just as a point of reference, this is the map of your disease intervention specialist regions. So as you can see, there are several geographic regions across the state of Iowa, and we also have 4 counties that have county level disease intervention specialists. So these are all listed here. This map will also be made available in your supplemental materials, which can be printed and kept on file. Keep in mind that this map can change from time to time, so we'll also include a link to where this lives on the Iowa Department of Public Health's webpage, so that you can access that regularly and routinely as needed. I also wanted to take a moment to highlight here what the landscape of the Ryan White program's HIV medical care and case management services looks like in the state of Iowa. There are 3 parts, there are 2 parts of the Ryan White program here in Iowa. It's Ryan White Part B and Ryan White Part C. Those Part C individuals organizations that you see there in yellow are funded from the federal government to provide HIV medical care. And the Part B individuals are funded through the Iowa Department of Public Health with support of federal funds to provide case management and other support services to individuals that are living with HIV. And you can see in a few instances that these are co-located across the state. So this is also an important resource to keep in mind as you are diagnosing and linking individuals with HIV to medical care and case management. And just a brief note on third-party billing. Payers will reimburse for HIV screening, assuming that the delivery of this service meets the standards of care that have been set by the payer. There's a supplemental recorded presentation that will be available to any attendees interested in learning more about third-party reimbursement for services related to HIV screening and diagnosis. That third-party billing presentation is brief, and it is a linkage to other pre-existing resources and coding manuals, and that presentation will address HIV, HCV, and STDs as well. And then just a few special considerations for the implementation of HIV screening in your practice. When conducting HIV testing as part of your services, it's important to develop capacity related to taking a sexual history, to assessing behavior risks, and to developing a protocol for managing clients who may have an emotional response to test results. There are a lot of tools related to best practices to all of these, just online, and that can be found through federal partners. However, if you need technical assistance or capacity building related to these skills, please do reach out to us and we'll be happy to assist you in that. I'd also note it's equally important to give clients time to process their response and their feelings when receiving a test result, whether that test result is reactive or non-reactive. It's not safe to assume that a client has a desired outcome that would match what your desired outcome may be related to HIV test results. So refrain from using language that assigns blame or assumes how a client should be feeling. Our job during the testing and diagnosis and linkage process is really to be educational and supportive in every way. So just make sure that we are practicing appropriate counseling skills and really having human-centered experiences with these individuals who are presenting for testing. And an additional special consideration is related to minors. In Iowa, minors may be tested for HIV without the consent or knowledge of a parent or other legal guardian. However, minors must be informed prior to engaging in screening that should a confirmatory test be positive, a parent or guardian must be notified by the agency that's providing the confirmation testing. Minors must also meet the minimum age requirements set by the device manufacturer, and should you choose to use a rapid point of care test, that can be found in the customer letter and in their guidance documents. Minors are required to sign a consent form prior to engaging in HIV testing, attesting to their understanding of this requirement. If a minor can't attest to that or they don't understand, then you should not offer minor testing at any time. Sample minors consent form language is available through our program, and you can email us at the email addresses listed here should you like to have a copy of that on file. And then I will say the last thing with this, there is a lot of language related to medical service provision to minors with or without the consent of a parent or guardian, and you can reference that at Iowa Code 139A. And so shifting gears just a little bit to HCV testing, and again, we'll just start with the CDC screening recommendations. And these also have recently been updated in 2020. Previously, the CDC was recommending screening for all baby boomers, so individuals born between 1944 and 1965. And those screening recommendations have recently been expanded to include a once-in-a-lifetime screening for all adults aged 18 and older and for pregnant women during every pregnancy. However, populations should be offered routine screening when presenting with ongoing risk factors, specifically persons who currently use injection drugs. That being said, any person who requests hepatitis C testing should receive it regardless of the behaviors that they're willing to disclose to you. Many persons may be reluctant to disclose risk factors due to stigma and fear of judgment or shame. And much like HIV, we'll now examine the HCV testing algorithm. And again, very similar to HIV, if you're using a rapid HIV screening tool, the rapid test would act as the first stage of this testing algorithm, and a conventional sample would need to be processed following this algorithm as shown. An individual may present with HCV antibodies and not have an active infection. And in this way, HCV is a unique infection and further confirms that confirmatory testing is crucial and vital as part of this algorithm. Because once an individual has been infected with HCV, they will always test positive for the HCV antibody, which is what a point of care test is screening for, even if they have cleared the virus on their own or effectively engaged in treatment. That being said, disclosure of treatment cannot be an exclusionary factor for confirmatory testing if somebody presents with an HCV positive antibody screen, because someone can be reinfected with hepatitis C after they have been treated or after they have cleared the virus. So the presence of an antibody positive plus reported effective treatment does not mean that there is not a current active infection if there has been risk since the treatment period. And this is where it becomes really vital to ascertain behavior and timelines related to that, the individual that's presenting for services. These are the test types for HCV in the window period. So there is an antibody test, which is a point of care rapid test. This can take up to 180 days or 6 months to identify HCV after an exposure. And the test type uses a finger stick sample specimen and delivers results in 20 minutes. It does require confirmation using the conventional method as discussed in the previous algorithm section. There are antibody tests that are conducted in the laboratory. These are exactly the same as the point of care test with the 180-day or 6-month window period to identify HCV after an exposure. And then we also have the nucleic acid test. Because HCV antibodies can remain present even if an infection is not active or has been cleared or treatment has been effective, this test detects the presence of an active or chronic HCV infection by looking for the active virus in the blood. This is the final step of the testing algorithm. Full information for the testing algorithm can be found at the link provided here. And as previously mentioned, these links will all be available in a supplemental document with this presentation. And then just to highlight the common point of care or rapid test, this is actually the only test available for rapid antibody diagnostics of hepatitis C in North America. Has a 20-minute processing time, and as we said, it's a finger stick sample collection. Market cost for this kit is just at about $20. But again, I'll mention that while this test is an effective tool for screening for HIV, it's very important to understand and communicate to the clients that you're serving that these types of tests are only screening tools and that laboratory confirmation is required to diagnose hepatitis C. This is particularly true given the fact that anyone who has ever been exposed to HCV will continue to have a reactive test even in cases where the virus has been cleared by the body or when treatment has been effective. You should also work with patients to develop a self-care plan during the time that they await the results, and that plan should include who are you going to discuss your test results with? Do you have a support network in place? Again, counseling clients not to broadly disclose their diagnosis and to await a confirmatory test result. And counsel the client that living with HCV is not what many perceive it to be. Medications are highly effective and have a very high success rate of curing the virus. Um, Also note the window period and recommend repeat testing for individuals who have reported ongoing risk or have any reported risk within the preceding 6-month period by recommending a second or repeat test at the 6-month mark from the last known potential exposure. If an individual is identified as having HCV antibodies and/or current active HCV infection, Iowa law does require, again, that the provider in the laboratory that conducts the confirmation screening report the results to the Iowa Department of Public Health. The most common method of reporting by providers is submission of the Iowa Disease Reporting Card, and this form can be submitted under fax at the number listed below. Again, information on these forms and contact information will be made available to you in supplemental information or supplemental resources related to these presentations. And while treatment for HCV is highly effective, access to treatment can be difficult to navigate due to sobriety restrictions, prior authorization requirements, and provider type requirements. So the best starting point is to refer HCV diagnosed individuals to care with a known HCV treatment provider. These providers tend to be very skilled in navigating the identified barriers related to treatment access and payer coverage. And the Iowa Department of Public Health does upkeep a directory of known hepatitis C treatment providers, which is linked here on this form, and again, will be linked in your supplemental materials. Payers will reimburse for HCV screening, assuming that the delivery of services meets the standards that have been set by the payer. And again, this will be addressed in more detail in a supplemental presentation on third-party billing related to HIV, HCV, and STDs. And again, in Iowa, minors may be tested for HCV without the consent or knowledge of a parent or other legal guardian. It is important to note, though, that if a minor is using insurance provided by a parent, guardian, or other individual, the policyholder may have access to information related to the provision of these services. Minors also must meet the minimum age requirements set by the device manufacturer in the event that you're using a rapid or point-of-care test for the screening and diagnosis of hepatitis C. And then finally, just a brief overview of STD testing. And by STD, I really just want to highlight that we're going to be focusing on gonorrhea, chlamydia, and syphilis, which are the reportable STDs in the state of Iowa. So for gonorrhea and chlamydia, all women who are sexually active and under the age of 25 should be screened annually, regardless of signs or symptoms. Women older than 25 with ongoing risk should be screened annually. So women who have multiple or new sex partners who have a reported history of STDs, signs or symptoms of the infection, reported inconsistent condom use, persons who are not in mutually monogamous relationships, people who have coexisting or a history of recurrent STDs, or have a history of exchanging sex for drugs, money, or other things that they may need. Men who are part of populations with a high burden of disease should be screened regularly as well. So sexually active gay men and other men who have sex with men should be screened annually. And this should include all extragenital sites, so throat swabs and rectal swabs as well. Young men in high prevalence clinical settings should also be screened annually. So adolescent health clinics, STD clinics, corrections, etc. And then also men who are increased risk of STD acquisition, which would follow the same standards as what was discussed for women above, including multiple and new sex partners with STDs, signs, symptoms, inconsistent condom use, the absence of a mutually monogamous relationship, or a history of exchanging sex for drugs, money, or anything else that they may need. And again, this is just a snapshot of the screening recommendations in whole, and there's a link provided where you can access these in total for to have on record or to view amongst yourself and your staff. For syphilis, the screening recommendations are a little bit different. Pregnant women should be screened at their first prenatal visit, and retesting early in the third trimester and at delivery is often beneficial to ensure somebody's status related to a syphilis infection. And also women at increased risk of acquisition, so signs or symptoms, partners with a history of syphilis, women who have male partners who have sex with other men would also fall into this category. And men should be screened if they're part of populations with a high burden of the disease. So sexually active gay men and other men who have sex with men should be screened annually or more often if at an increased risk of acquisition. So if they're reporting new or multiple sexual partners, or if their partners have multiple partners within a time frame, they should be getting screened more often than annually. Persons living with HIV should be screened annually is the recommendation. And others at increased risk for acquisition, so signs, symptoms, partner with an STD, etc. And this is just a brief visual of what the testing algorithm for chlamydia, gonorrhea, and syphilis looks like. And this is available at the link that's provided on the screen. And note here that there are different collection types, so urine, swabs, and then blood for syphilis, which is important to note. It's also important to note here that syphilis can be identified with a rapid point of care test, but much like HCV, a rapid test will always be reactive if an individual has a history of syphilis infection. And for that reason, often conventional blood draws are the most efficient method of diagnosing somebody with syphilis or screening somebody for syphilis. Also, just as a point of reference, self-swabbing is a recommended method of sample collection for individuals when addressing extragenital screening. There are several visual aids available to have in your clinic or bathroom area to help provide instruction to individuals about collecting vaginal, oral, or rectal swabs for chlamydia and gonorrhea screening. If an individual is identified as having an STD, it is important to refer them to a medical provider to access treatment if you don't provide treatment on site. Iowa law also requires the diagnosing provider and the laboratory report the results to the Iowa Department of Public Health. And the most common method of reporting by providers is submission of the Iowa Confidential Report of Sexually Transmitted Disease. This form can also be submitted via fax to the number that's listed on the form. If you have questions related to STD reporting or you need a copy of the form, you can contact the STD data coordinator at the Iowa Department of Public Health, Katie Kramer, at the phone number that's listed here on this slide. You may also want assistance when referring individuals who test positive for STDs to appropriate treatment. And again, I'll just say that Iowa has a really robust network of state and local disease intervention specialists who can assist you with this process. You're encouraged to contact them prior to meeting with the client to ensure that you have updated information on where to refer for treatment. In certain cases of STDs, specifically syphilis and sometimes with gonorrhea, a disease intervention specialist may also contact the individual to offer partner services, which is the process where the DIS will help them ascertain which of their previous or current sexual or needle sharing partners need to be screened or treated for the STD. And again, as with HIV, the DIS can provide an individual with tools to notify partner themselves, or the DIS can notify the partners anonymously on behalf of the client or patient. Payers will also reimburse for STD screenings, assuming the delivery of the services meets the standards that have been set by the payer. And again, third-party billing will be addressed in a supplemental presentation made available to you. There are additional special considerations with minors. So in Iowa, minors shall have the legal capacity to act and give consent to the provision of medical care or services to the minor for preventative diagnosis or treatment of a sexually transmitted disease or infection by a hospital, clinic, or healthcare provider. Such medical care or services shall be provided under the supervision of a physician licensed to practice medicine and surgery or osteopathic medicine and surgery, a physician's assistant, or an advanced registered nurse practitioner, and consent shall not be subject to later disaffirmance by reason of such minority. So the consent of another person, including but not limited to the consent of a spouse, parent, custodian, or guardian, shall not be necessary. So there is specific language beyond what we have discussed previously in this presentation related to a minor's right to access sexual wellness services in the state of Iowa. And again, I would refer you to Iowa Code 139A, which we will link in your supplemental materials. And so I've said supplemental materials several times during this presentation, so I just wanted to give you a snapshot of what this looks like. There will be 2 additional recorded supplemental presentations for your reference, one focusing on third-party billing for HIV, HCV, and STD testing, and then a second supplemental presentation that will review device training for the INSTI test, the Determine test, and the OraQuick HCV test, just to give you context and background, should you be choosing to use a rapid point of care test as part of your process when implementing screening. These presentations are available now, and you can access them in the same place that you access this training. And then we also have made available a PDF supplemental reference document that includes active links for all the links that will be shared during this and the supplemental presentations as part of this series. And so with that, I would just close by saying thank you so much for your interest in implementing HIV, HCV, and/or STD screening in your setting. My name is Cody Schaefer, and again, I'm Prevention Services Coordinator. Also listed here is Biz McChesney, who's the Program Manager for HIV and Hepatitis in the Bureau of HIV, STD, and Hepatitis at the Iowa Department of Public Health. You are welcome to reach out to either one of us individually, or we do have a shared program inbox, which is listed here as well. Feel free to use any of these mechanisms to reach out to us should you need clarification, additional resources, technical assistance, or capacity building assistance as you go about implementing this project. So again, thank you very much for your time today. Please explore the supplemental presentations and resources that are available to you, and don't hesitate to reach out if you have any questions. Thank you so much.